Hi everyone. So I've got a nice ECG that I'd come across, and was hoping to share it with all of you. Let me just get this started, and then we can have a look. So it's a very nice ECG that it managed to come across, and this is actually from X, as it's known now, and was posted by one of the regular contributors there, which is the ECG collector. It's a lovely Twitter handle to follow, or X handle to follow. And yeah, so this was just one that I'd come across that I thought everybody could benefit from. So what we're going to do is we're going to quickly analyze this and then just go through some things that are quite pertinent when it comes to it. So the first thing we're going to look at is, let's just have a look at the axis as we normally do. I just want to make sure I've got everything here correctly. Yeah, so if we had to draw quadrants as we normally do, we've got normal, left, extreme right, and we've got lead one that we're going to look at, and lead AVF. And as I always say, this is not the only way to figure out your axis. It's just a way of figuring it out. So let's look at lead one first. So lead one, as we can see here, is primarily positive, which means that the lead one is actually seeing electricity moving towards it. So it's either in the left or in the normal. And then if we look at lead AVF, we can see that it's also positive, which means that electricity is moving towards lead AVF, which means it's either there or there. So since the two coincide in the normal, we can actually say that we've got a normal axis over there. And let's look at the rhythm. So if we start first with our P waves, let me just get that up here. So if we start with our P waves, we can see our P waves are relatively normal. Our PR distance, okay, we've got one anomaly over there of a large P wave, but that could also just be the patient movement and things like that. We've got about 4.5 blocks. So we're just outside of normal, which is between 2 to 4 blocks. So let's look at another example and see if we can pick it up somewhere else. Let's have a look there. And here we can see again, it's just above the 4-block mark. So it's borderline, but you could say the patient has a first-degree heart block. I don't think anybody would argue with you on that. And here we can see we've got a narrow QRS complexes. We've got a QRS following every P from what we can see over there. There's just the one anomalous here. And then they are relatively regular. So here I suspect there may have been some patient movement or something that may have just led to that. And that could be the reason why we just have that anomalous there. And here we have a biphasing. So it could have just been a bit of patient movement on the rhythm strip as well. And considering how lead 2 is set up, in that lead 2 is looking at, it's an augmented lead. So it's taking leads 1 and AVF and then actually creating a new lead. So if there was movement of the hand or the leg, it could have led to this as well. So let's have a look at the zones. So we can start first with the inferior zone. So the inferior zone, we've got leads 2, 3, and AVF, and we can see quite obvious ST elevations. So we can already suspect that, all right, we might have an infarct, especially if this patient is presenting with a chest pain, So the one thing that we can see, and one thing I always do whenever I've got a patient who's got elevations in leads 2 and 3, I always compare the two. So here we've got 1, 2, we can say 3 blocks between the neutral and the ST elevation. And if we go to lead 3, we've got about 1, 2, 3, just about 4 blocks, so slightly higher. So it's a rule of thumb that whenever lead 3 is higher than lead 2, the ST elevation that is, we can say that we've got a right-sided extension as well. So we've got an inferior, possibly a right-sided infarct that we may need to look at as well. Okay, let's look at the next ones that we have. So if we look at the septum, V1, V2, here we can see ST depressions that are occurring over there. So this could be reciprocal changes, or it could be something else, which we'll get to in a second. We come to V3 and V4, and in V3, we can see what looks like an ST depression, even though it's mild. And then we come to V4, and it looks almost like an ST elevation. On V5, we don't see much. And then on V6, we see what seems to be also a bit of an ST elevation. And then on leads 1 and AVL, well, on lead 1, there's not much. And on lead AVL, we've got an ST depression over there. So if you were to treat this patient as an inferior infarct with what you call it, ST with reciprocal changes, that would be perfectly fine. The one thing that's just a bit off-putting is the V2. And even the V1 here, you can see there's a slight depression. And here we've got, like I said, the slight elevations. And we know that we've got inferior and right-hand side, and the posterior part of the heart is also part of that arterial network. So there is a possibility that we've got an inferior infarct as well. Now, V1 and V2 sit directly across the back of the heart. So sometimes when you see these types of changes, in other words, V1 and V2 getting ST depressions, there's always a possibility of a posterior infarct as well. And leads V5, V6, AVL1, even V4, they also sit across, well, they sit sort of across from it, but to a lesser extent. So sometimes you do also see these abnormal ST elevations and ST depressions. So immediately, the first thing that you would do for this patient is, number one, with it being a right-sided infarct, suspected right-sided infarct, you don't give them any sort of nitroglycerins whatsoever, TNT, whatever it may be. The reason being that right heart is very dependent on the preload that's coming into it. And as soon as you give TNT, you cause severe vasodilation. So if you've got your heart sitting over there, let's try and draw it out. I'll do my best. So let's imagine our superior vena cava is coming in there. All right. And then we've got our right atrium. All right. That's sitting over there. And with its valves, of course. And then we've got our right ventricle sitting here at the bottom. Right? So the right ventricle here is very dependent on the inflow for it to be able to stretch and then contract. And once you've got damage, so if, for example, let's say you've got a right-sided infarct, and now you've got damage along this entire area, let's say, for example, and maybe even going to the posterior and the inferior. If you pump less blood in here, it's going to be much harder for it to now pump blood out again because it's already damaged. So once you give nitrates, any sort of nitrate, what happens is that you increase the diameter of your SVC, your superior vena cava. And once you do that, you've got to imagine it's sort of like a column. So, with the IVC and the SVC. So let's have a look at it there. So let's say you have a wide column here at this side. And if you put it back in blue, we could say that initially before the nitrates, you would have had a much thinner column of blood. So the thinner column of blood is under a much higher pressure simply because it's thinner. All right. So let's say the level was here. Okay. Let's say just as an example, you had blood that was right up to here, and every time you breathe it in, you managed to get it in. Without, with that amount of effort. Now, once you've given nitrates and they increase their diameter, as with any tube, once you increase the diameter, the level in the tube, because you've got the same amount of fluid, it will automatically drop. So it takes a lot more effort now to bring that blood into the right atrium and the right ventricle. So your pressures start dropping. And as you pump out less blood through the rest of the circulation, you start dropping this more and more and more and more. And basically you cause a death spiral for your patient. So the first thing we do is not give TNT. We can, of course, give morphine. We can, of course, give any sort of analgesic that you are recommended to give in your institution and follow the protocols of your institution. I'm just, as a general rule, try to avoid nitrates in these patients. So, okay, we've sort of guessed, or we've sort of come to the conclusion that this is a inferior infarct, right-sided infarct, and possibly posterior. So the question is, okay, I think it's a posterior infarct. What do I do now? What can I do? So this is where you might hear your your consultant or your senior saying, all right, let's do a 15 or an 18 or a right-sided or a posterior ECG. And some of you may have never done it. So this is how you do a right-sided ECG. So it's the exact same as as your normal ECG, the only difference being that you now place the leads on the mirrored side. So whereas V1 would have normally been here, and now you just switch them around between V1 and V2. V3 would have normally been here. Sorry, let me just get the spotlight on this. So V3 would have normally been there. V4 would have been here. V5 would have been here in the mid-axillary, anterior axillary, and V6 would have been there in the mid-axillary. So now all that happens is that you switch it over to the right-hand side. And when you do that, you label it as such. Now, I must be honest, when I do the right side, I don't normally switch V1, V2, and V3. Normally just do V4, V5, and V6. And then we label them V4R, V5R, and V6R so that you know that you've done a right-sided. Now, if you want to do a posterior one, then we're going to have, well, let's say we came up to V6 more or less here. You will then do V7, V8, and V9. So it's not a new machine. You're just basically moving out V4, V5, and V6. So this is what you do. So V7 is at the posterior axillary line, in line with V6. All right, so you're still at the 6th intercostal space. V8 is at your scapular line, or at the point of your scapula, and V9 is then paravertebral. Okay, so that's how you get these 15 lead and 18 lead ECGs from your standard 12 lead ECG. So you now sacrificed your V4, V5, and V6 in order to get leads V4R, V5R, V6R, or V7, V8, and V9. And remember to label it as such, otherwise you're going to have issues. It's going to create a lot of conundrums for you if you haven't labeled it, and to make sure that you know exactly what's going on, and so that you can explain to people what you've done. So this is a lovely ECG that I found from Life in the Fast Lane, which if any of you are not following, I suggest that you follow, because our doctors there are doing such amazing work. I've been following him for years, and really it's an amazing website, and the stuff that they put on YouTube, and the entire website and videos are just amazing. So I would really suggest joining up to them. In this one here, you can see a more typical posterior infarct, where V1 and V2 are still showing ST depressions, and we have slight ST elevations in leads 2, 3, and AVF, ST elevations in 1 and AVR, or let's say lead 1. So now what they've done is they've gone and put V7, V8, and V9 to look at the posterior of the heart. And what you can see quite clearly are these ST elevations now on the posterior part of the heart. So once you see that, then you know that you've got a posterior infarct as well. Why is this important? It's important in terms of prognosis. It's important in terms of treatment. It's important in terms of how your cardiologist is going to treat the patient, So that's what I would suggest that you make sure that you have a look at and see. Okay. All right. I hope you guys enjoyed that, and hopefully we'll have another one soon. Keep well. Bye.